Hello, thank you for coming. I know this is mid-afternoon and you're getting tired, but especially you must be getting tired of screens and Zooms, but we are really glad that you came. So welcome to Advancing Maternal Health Equity with Policy that Delivers. Um, First of all, my name is Cheryl Roberts and I'm the Deputy for Program and Operations for the Department of Medical Assistance Services for the Commonwealth of Virginia. And I'm also the Health Systems Performance and Public Health Steering Committee Chair. And I'm laughing about that because if you can repeat that 4 times fast, I will send you a gift card. Anyway, so what happens at this meeting is important, obviously, in terms of talking about maternal health. The presentations are available on the platform as well as on the app. If you have not taken the time, you should need to download the NASHB app. It has lots of great information. Also, the biggest thing we want to talk about is that you must do the evaluations. The evaluations give us feedback individually and corporately. And so before you leave here, make a commitment to just do the evaluations, as well as doing the evaluation of the entire conference. Let's talk a little bit about why we're here. Obviously, Medicaid is a big deliverer of babies. About 45% of the deliveries in the country are delivered through the Medicaid delivery system. However, the statistics also show that poverty and race do have a big impact on maternal and infant health. Women of color have seen increased infant mortality and complications with their deliveries, as well as with their postpartum services. And we also saw statistical differences in both urban and rural areas. And so as a result of that, states decided not to just focus on policy, but actually to do some definitive actions that would change the trajectory. And so that's what you're going to get to talk about are 3 things that states are doing to actually make a difference in the overall health for women and children. So one of these we're pleased is that NASHB has a commitment to this area that goes beyond this conference. One of the things they're doing is a NASHB PIP Academy, which is also funded by HRSA. And right now they're working with 8 states for 2 years to improve access to quality care for Medicaid eligible pregnant and parenting. This is the second cohort. They've also done the first one that was completed actually last year. But what you also should do if you get a chance is to sign up for NASHB's newsletter. The newsletter is fabulous. It's about a maternal child health monthly newsletter. Loved getting it. Use it and give it to my staff, as well as they're available to give technical assistance. So if you see things here that you are interested in addition to talking to my colleagues, you always can talk to NASHB and they can help you walk through how to make this a reality for you. I'm pleased that I have a team of people who are here to speak who are really our trendsetters and are passionate about the topic. You can't get better than them. We looked across the nation and honestly, these 3 people are at top of their game for the topics. You're going to hear from Lynette Rose, who's the Executive Director of the Medical Assistance Division for Georgia, and she's going to talk about postpartum and one of the first states, obviously, to do the postpartum waiver. We're going to talk to Jennifer Langam Jacobs, the New Jersey Medicaid Director, and she's going to talk about how she transformed the whole concept of community doulas. Virginia will be following her. She's number 3 in the nation. And then last but not least, we're going to be talking to Dr. Zachary Hairston, who is the dental consultant for DMAS in Virginia. He just brought up adult dental, but before that, he brought up dental services and oral health for pregnant women. Want to remind you, again, is that their full bios, you can actually get to see them, they're online. What we're going to do in order to get through this is that we're going to go through all 3 presentations. You can write your questions and your comments in the chat. At the end, we'll do all your questions and answers. And if you have to leave early, don't forget to do your evaluations. Okay, so first person up will be Lynette Rhodes.
Hi, good afternoon. My name is Lynette Rhodes, and as Cheryl indicated, I am the Executive Director of the Medical Assistance Plans Division with the Georgia Department of Community Health, and it is my pleasure to be here with you this afternoon. I'm sure we could advance down to, I think, slide number 4. One more, right there. Thank you. Let's one, Cheryl. I'm going to start off by giving just some general information about the Medicaid program and just some very high level statistics. And so Cheryl, if we could go back just one slide. As a starting point in the Georgia Medicaid program, we currently enroll 2.4 million Medicaid and CHIP members combined. Enrollment has definitely increased since the start of the public health emergency. So I do know that all Medicaid programs are experiencing the same increase in enrollment at this time. In Georgia, we operate 2 delivery systems. We have managed care and we also have fee-for-service. Approximately 75% of our population is served through managed care, with the remainder being served in fee-for-service. Right now, we have a very small number of pregnant women who are disabled who receive services in traditional fee-for-service Medicaid. So the slide that's before you just gives you a better picture of the breakout of the various populations. So if you look at the pie graph that is to your immediate left, you'll see there that the LIM population, that's our low-income Medicaid population, represents 55% of the beneficiaries. The ABD, which is our aged, blind, and disabled, represent 18% of the beneficiaries that we serve. You'll see where it says PCK, that is our CHIP program. And the branding in Georgia is Peach Care for Kids. So we use PCK from time to time, but that's about 5%. And the department also provides insurance to the state health benefit beneficiaries who are state employees, retirees, and their benefits. And their dependents. If you look at the pie graph to the right, that further breaks out for you the percentage of children and pregnant women that are in our LIM population. So as you can see in the state of Georgia, the majority of our Medicaid members are actually children, and then you have pregnant women, and then your low-income caretaker. So next slide, please. All right, diving right into today's topic, we're going to start to talk about pregnant women, postpartum coverage, and the landscape in Georgia. So as Cheryl mentioned in her introduction, the Medicaid program covers almost 50% of births nationwide. In Georgia, we actually cover 50% of all births in the state. So I provided for you here some numbers for state fiscal year 2020. And for us, that's the time period of July 1 of 2019 through June 30th of 2020. And so you can see here that Georgia Medicaid covered 110,000 pregnant women. Of those, we covered 69,000 births under the Medicaid program and 76 births under the CHIP program. For state fiscal year 2021, I also took a look at those numbers. And so that's the period of July 1 of 2020 to June 30th of 2021. And so in the state of Georgia, for the entire state, for state fiscal year 21, there was approximately 110,000 births for that particular year. And Medicaid covered 52% of those births, which is significant. So Georgia Medicaid covered 57,000 of those births, and the CHIP program covered 58. So again, just in full support of the comments and statistics given by Cheryl in her introduction. So next slide, please. All right, so some more specific information on the state of Georgia. Here I want to talk about maternal mortality and morbidity. Previously, Georgia was ranked as one of the states with the highest maternal death rate in the nation. This was actually a report that came out in 2010 from an organization called Amnesty International. And so they produced a report that ranked the state of Georgia 50th nationwide. And so as you can imagine, that was of huge concern to us in Georgia. And so as a result, our governor established a maternal mortality review committee to study these particular issues to find out why why the number of deaths was so high in Georgia. And so in 2019, our General Assembly passed the resolution that created a study committee. And that study committee actually reported out 3 recommendations. And so what they found was that 60% of the deaths were actually preventable. So next slide, Cheryl. All right, so here we give the breakout of what the findings were. So if you look at rural versus urban, and this is probably not very shocking to anyone, women who live in rural areas have a much higher maternal mortality rate than women in urban areas. And some of the barriers included access to care, transportation, social services, and social determinants of health. So when we talk about barriers regarding access to care in rural areas, we're talking about things like lack of providers, no OBGYN in those particular areas, or we're talking about what we experienced in Georgia, which is a number of hospitals in rural areas that closed down. When we look at the area of social determinants of health, we're talking about food deserts, housing, income, and education. So those are all areas that we have closely monitored over the years and are now working diligently to make sure that our members have access to all of those services. When you look at age, women over the age of 35 had a much higher ratio of deaths as compared to women under age 35. And many of those deaths occurred during pregnancy. And then with respect to race, African-American women had 3 to 4 times higher ratios as compared to Caucasian women. Next slide. All right, so what was Georgia's response to these particular findings? As many of you know, pursuant to federal law today, states are only allowed to cover 60 days of postpartum coverage. So in July of 2020, Governor Kemp signed into law House Bill 1114, which allowed us to extend postpartum services from 60 days to 180 days. So this was very exciting for us. We are actually one of 3 states, Cheryl mentioned, who have actually extended postpartum coverage today. So you've got Georgia, Illinois, and Missouri. So in order to make this happen, we did have to receive appropriations and funding to do so. So we received $59 million in appropriations in order to go a full-blown 6 months. We submitted our waiver in December of 2020, and it is now in effect as of July 1 of 2021. Next slide, please. And so, one of the points that, we do want to definitely make sure to point out here is that there's still a question on the table about potentially moving forward to 12 months. And I'll touch on that in just a moment. Here we've outlined the primary goals, of course, which is to reduce maternal mortality and morbidity in Georgia. In terms of eligibility, the thing to point out here is continuous eligibility is provided during the entire postpartum period, and that is regardless of a change in income. Once we've reached that 6-month mark, then we will, behind the scenes, without the member having to take any initial steps, we will then check to see if that member is eligible for any other services. If they are, we will automatically transition them to that coverage group. And we also added the resource mother component, which in Georgia is basically case management, which will assist that mother with locating community resources and assisting with the social determinants of health. I think the last thing to mention here that many of you are aware of, I'm sure, are the new provisions under the American Rescue Plan Act, which was signed into law in March of this year. And so under the American Rescue Plan Act, states may now moved to a period of 12 months of postpartum coverage. So this is huge for states, and something that I'm sure many states will take advantage of. And so that opportunity becomes available to states in April of 2022, and will be available for a period of 5 years. And so with that stated, Cheryl, I'll transition back to you or to the next speaker. Thank you.
Thank you, Lynette. People are going to have questions, and if you do, put your questions for Lynette in the chat, and that way we'll be able to gather them, because I have now questions, and they can gather them. We'll talk about it at the end. And next will be Jennifer, who will talk about the doula benefit.
Thanks, Cheryl. Yeah, Lynette's got it covered, getting everybody eligible, and we're following you down that path, Lynette, for the extended eligibility. I'm here to talk a little bit about doulas. That's how Cheryl and I met a couple of years ago, when doulas were a twinkle in our eye, and we have headed down this path. So I'm really happy to be able to share it with you today. Let's go to the next slide. The first thing I wanted to do was give you a sense of context. Like Lynette described, New Jersey has really challenging maternal child health metrics. Maternal morbidity and infant mortality are very concerning to us from a social justice point of view, from healthcare outcomes point of view. It's work we have to do, and it was all hands on deck. So First Lady Murphy set up an interagency work group, and we worked through discussions about what each part of state government could bring to the table to move these numbers and get better outcomes for people. And that is now our strategic plan, which we refer to as Nurture New Jersey. There are a lot of components to that. It's a pretty dense document, but I think if you're being honest and really trying to address the major challenges that we have today, you've got to be thinking about it from every direction. So we've been part of this initiative, but not the whole thing. Just from a Medicaid point of view, we wanted to share in the blue box some of the initiatives that we have underway right now that are separate from doula, just so that you can see the context. For example, we rolled out in 2019 family planning coverage, separate from Medicaid, but for people who didn't have family planning coverage, and the centering pregnancy benefit. And then, then we took a break for a minute to have a global pandemic. I don't know about you guys. We're still working through that, but January 1st of 2021 was a big day for us from a rollout point of view, because that's when we started requiring a perinatal risk assessment form to be completed by our providers providing prenatal care in order for them to get paid for that prenatal care. So the intention there was like, give us that assessment. Let us all understand the risk involved so we can hold our managed care partners accountable and make sure this woman is getting the care and resources that she needs. And so that was new policy. The same for early elective deliveries. We set a group of codes that we recognize to be appropriate for an early delivery, and those should be present on the claim if we're going to pay for an early delivery. So that was new policy on January 1st of 21. And then, of course, we rolled out our community doula benefit. So a bunch of other things are in the pipeline, but I'm here today to talk to you about the doula piece. Let's go ahead and jump to the next slide. I wanted to talk for a moment about community doulas and what we mean when we talk about that. This was an initiative that, as I said, this is a whole of government approach. So this was really an initiative that started with our partners at the Department of Health, and my counterpart, Assistant Commissioner Lisa Asari, was in the lead on that, working with community doula organizations. There are doulas all over the place who are well trained to assist in delivery of a baby and support from a perinatal point of view. But we really wanted to make sure that we were emphasizing the community component here so that we were sure we were getting two things. We're not always sure a doula is prepared to deliver. One, culturally competent care. It was absolutely essential to us that the doulas we provide through the Medicaid program understand what our members are up against, that their lived experience, and what they may experience when they're working through the healthcare system. And so having that culturally competent care was a critical component of our program design. The second reason we were really focused on community doulas was we wanted them to have the community-based training that would ensure that we could think about the whole person. So as that birthing person is going through the system, is sort of managing prenatal care, managing a new baby, what are the resources that are available to them? And particularly, we wanted our doulas to have some familiarity with trauma-informed care and to be very aware of what our local social services ecosystem looks like. So ensuring that we had doulas who were prepared in that way would let us get the outcomes we really wanted. So not just any doula training, but community doula training. And that took a little bit of getting there. There was plenty to talk about on that subject, but our goal really was to leverage what the March of Dimes saw, which was the potential for women to help each other through what is a life-changing experience. Let's go to the next slide. And there, I just want to talk a little bit about the path that we took to design. So if you go to the beginning of this blue arrow, that's about where Cheryl and I met when we were in the early stages of this. And we started working with our stakeholder group of doulas. They were from all over the state of New Jersey. And that included both urban and non-urban communities. By some definitions, New Jersey is 100% urban, but we don't see it that way. And so the doulas came to the table with us. These were the old days. We met in person. They made time in their schedules to do that because they recognized the value of those face-to-face relationships. I will say Zoom has been good to us. During the pandemic, Zoom has sort of taken the walls down. More people can participate. We don't have to worry about the size of the room, and they don't have to travel. So we've tried to keep it very conversational, but that stakeholder group with Department of Health and the community doulas who were already out there, the nonprofits and foundations that were supporting them, and our managed care partners, like that was a big group, and that dialogue was really important. We landed on some key things. We needed that community doula expertise, right? You could have gone with any doula preparation, but for us, we felt that having that community expertise was really important. We heard from the doulas that people need their care and support before, during, and after labor and delivery. And so we wanted to make sure that we had that full spectrum available. And so when we were setting up the benefit, we said, okay, that means that in some cases, the doula and the birthing member are going to meet up a bunch before labor and delivery and not a lot afterwards. Maybe the opposite. We didn't want to get in the way of that. We wanted the birthing member and the doula to make that decision together. And the other thing that doulas were really clear to us about was don't force us to work under clinical supervision. They'd had some experience with that in other states. They see themselves as partners to clinicians. They very much want to be part of that larger ecosystem, but they didn't want to be forced to work under a clinician. So it's a non-clinical role, and that became a part of our program design. Then after all those conversations, many of them in person and then eventually over Zoom, we went live with our doula benefit in January. So we are now in operational phase. I'll talk about that in just a moment, but we've added some stakeholders now, right? So now we have doulas who have enrolled with Medicaid, doulas who are participating in managed care organizations. They have signed a contract. And we have the Department of Health's Doula Learning Collaborative. That was an important outcome as well, because we recognized that the doulas needed an infrastructure of support. We're building a workforce here. There's no billing operation out there to support doulas. There's no credentialing operation out there to support doulas. So they really did need that infrastructure and community. Let's jump to the next slide. Our benefit is available to all of our birthing members as I said, they can visit before, during labor and delivery, and after. They can go to home or to a doctor's appointment with them. We made sure to provide extra visits for very young moms, which we saw as a little bit of an indicator for high risk. And we thought we would consider over time adding additional visits for other high risk indicators. And so that was also from doula feedback. And then we added an incentive. So if the member goes to her OB for postpartum follow-up, the doula gets an incentive payment. That is to help our doulas help us to get those members to those follow-up visits. And let's go ahead to the next slide. Oh, the only thing I should mention as we do that, and that it's okay, go ahead to the next slide, thanks. It is part of the technical and adaptive challenge concept. One of the challenges being that they didn't have that infrastructure of support. They very much wanted to practice on their own. Don't make me join a home health agency. Don't make me join a doctor's office. I just want to practice on my own. We also recognize the technical challenge for doulas of managing billing and stuff like that. So in addition to allowing them to practice on their own, we created doula agencies as an option so that if a group of doulas wanted to get together, they could do that. It's a good quick transition to technical versus adaptive challenges. This is where it's at for us right now. Technical challenge, of course, is all the things we know how to do. We just have to do them. And the stage we're at with that is right now we're waiting for claims. Like that's the moment. We know that members are getting services. As they say in Tennessee, members get services, providers get paid, right? So we know members are getting services. I got to make sure providers get paid. That's the moment we're in. And then the adaptive challenge, and I wish I had not run out of time here, but the adaptive challenge really is we've got to get people thinking in different ways about how birthing occurs, the ecosystem around it, making sure that doctors understand the role of doulas, that hospitals are allowing them in, especially during the pandemic, that our community doula workforce is growing and growing and growing. We started with that initial sort of seed group that had worked with Department of Health. We want to grow that out so that we have doulas for everybody. And then just continue to make sure that they have sort of become a part of our system, part of our ecosystem, and can be there to support our members. That's it from New Jersey, Cheryl.
Well, thank you again. Oh, again, I would say I have questions too. If you have questions, put them into the chat so that we can have them. And I do have another factoid for us. I had one of the fellows for NASHB, and it turned out she was working with me on the doula project, and it turned out her mother was working in the New Jersey doula project. And did you know that? You didn't know that? Yes.
I did not. That's so fun.
Yes. Yeah. One of your people. So I thought that was interesting to show that we had ties.
Yes.
Okay, and last but not least, we're going to talk about oral health and pregnant women benefits. And Dr. Hairstead is important to the Commonwealth, but also he taught me, which I'm going to give lots of credit, about how important oral health is beyond having beautiful teeth. And so I'm going to give him a chance to talk about his work with pregnant women.
Thank you, Ms. Roberts. Good afternoon to everyone. Our current model for pregnant women benefits, had its genesis in 2005. We completely revamped our most important program, How We Perform with Kids, our Smiles for Children program. We brought on a dental benefits administrator that still holds today. We moved from providers that were exiting to over 1,900 strong today. But we also created a village of stakeholders, groups that would come to know and become influential and able at dentistry, yet not be dentists. A dental advisory committee was created with some 15 to 20 members. Dentists and many of those dentists still serve with us today from the Dental Advisory Committee. In 2021, we included many other external stakeholders, from insurance administrators to folk with an interest in ID populations to elderly. We have 2 large state dental organizations, having the executive director from the largest organization with over 6,000 dentists, and his very personal front focus to do what is so important for kids was remarkably impactful. And he still serves with us today. Today's program is about maternal. All the things I just mentioned made our glide path to creating maternal benefits easier. In this slide, I wish to note year 3 and year 4 for unique pregnant women claims. Almost 7,000 in year 3, year 6 is 2020 and COVID influenced. So you see somewhat of a bell curve there, but that is not by statistical design. Next slide. At our peak year, which was 2016, I'm sorry, $6.7 million is for unique pregnant women claims. I'll ask that you keep those 2 numbers close in mind. The slide before was just under 7,000 and $6.7 million on this slide for our highest year, which was year 3. Next slide. One of the most important reasons Virginia has been successful is the governor. That holds for 2015, and that shall also hold for 2021. I'll talk more about that later. The governor created a Healthy Virginia initiative, and there was an initial allocation of funds for 3 years. Language used then, just as now, created a focus on oral health and overall health. Again, that's going to be quite impactful when I speak about adult dentistry. We created a multi-front team, partners, if you will, an all-hands approach to each of these groups speaking the same language. And many of those groups are listed in the second bullet. The Dental Advisory Committee mentioned earlier, both state dental organizations, American College of OBGYNs, Virginia Academy of Family Physicians, FQHCs, and we're fortunate to have Virginia Health Catalyst. This is an arm where the executive director and her entire staff is focused on dental, from legislators to grassroots organizations. The benefits administrator began a series of webinars, and these webinars and posters were for dentists and to educate new moms. Medical doctors were brought in terms of trying to educate them and their staff. And we had what was called a Smile and Stalk program. All of these were done as initiatives for the pregnant women benefit. I'm aware of at least a couple of offices that were taking dental packets to the OBGYN offices in an effort to have them dispense these packets to the new moms and go ahead and start the initiation process to have them talk with a dentist. One of the things I will say from a clinical perspective as well, if there are new moms coming into the office and they come with their mom, sometimes it's good to approach the new grandmom to be about why the daughter should be receiving treatment, and all during the before delivery time frame. Next slide. So there have been some challenges. Many times the new moms will say they're working and they're trying to go through this work process before they have the baby. So the 60 days postpartum thing that was brought up by Georgia is in fact one of the things, but we do have a way of addressing that in adult dental, as I'll explain later. The second bullet is something that we did more than a few webinars to try to get in front of. And what happened here is the dental benefits administrator, because they were managing any number of different programs and insurance recipients, they decided that the best way to do this is character-specific language that should be written on the ADA claim form. And this was language that's, you know, pretty straightforward in that patient is pregnant, delivery date is, patient was pregnant, delivery date was. And the providers should fill that out. Well, as many webinars that were done still did not go down to the provider level in that they took care of this on that particular line. As such, many of the claims were rejected. And it put a process in place where it started to question, the office reference manual started to question whether the code was in fact covered, because pregnant women benefit codes were different from Smiles for Children codes, our 0 to joint age group. So if there is for the listener, if you're gonna bring on a program for pregnant women benefits, if you can just correct this one nuance, there could be blue skies when it comes to claim submission. One of the things that created just a little bit of a area that we have to have a room for improvement was dentist hesitation. Senior dentists just a bit more than some of the younger dentists, in that there is a reluctance to treat pregnant women. And pregnant women treatment is safe. One of the things that can be done to somewhat get around this, if the dental office, if the front office had a stock form that they could send to the OBGYN and just kind of get a read on whether or not it's okay to treat the patient, which trimester might be better, if there's any medication to avoid, whether or not it should avoid epinephrine, and if there's medicine that's necessary for, you know, the pharmacy, would this particular OBGYN like to be prescribed? So there is some area there that could be some tweaking. Next slide, if you will. So when treatment is being done, and this is fresh data now, January to December of 2020, there were 36,827 deliveries that received a dental benefit. Diagnostic and preventive measures are the leaders. Diagnostic at 15.4%, preventive at 7.2%. So for states out there to question if they could bring on a comprehensive, robust schedule of dental benefits, the data suggests an ambitious, cost-friendly, diagnostic preventive services plan could be impactful. Restorative procedures are 6.7%. So crowns, endo, and periodontics are all under 3%. That could be a measure of if there is some continued dentist hesitation about starting long-term procedures and not getting in before that 60-day postpartum. So who is receiving treatment? Age 35 to 39 is highest at 21.2%. Age 21 to 24 is lowest at 15.7%. So the other 5-year windows of treatment are all around 20-ish%, 20 point some number, but age 35 to 39, again, this is from last year, this is fresh data. Age 35 to 39 is highest. Who? Asian, non-Hispanic is highest at 29.3%, where any prenatal, perinatal dental service was received. Next slide. While our focus today is maternal, there has been carryover to adult dental. First, the numbers. Have your eyes focused to the right bar graph. The third bar from the left, the gray bar, we're looking at the right graph now, that gray bar to the deep blue bar is the very first month of adult dental benefits. 19,932 unique members were seen in the first month of adult dental, beginning July 1 of this year. The rusty red over to the second month, the rusty red color that goes over to the dark color that ends on 8/28, the second month, 27,569 unique members were seen. So from July 1 through September 11, 64,829 unique members were seen in our brand new adult dental benefit plan. And I ask that you keep in mind the number 6,800 from pregnant dental benefits. 6,800 was our highest in 1 year. 64,829 is in 2 months. Next slide. When I asked you to keep the number in mind for pregnant women benefits, 6.7 million was our highest in 1 year. Since July 1, it says at the bottom of this slide, since July 1, there have been 13.8 million in total paid claims since July 1st. Next slide. As in 2015, 2021 also presents Virginia with a favorable inclined governor that is also a physician. So that has helped to bring on the adult dental benefit plan. We use the same playbook as maternal in that we provided frequent webinars for providers and members. We brought on all of the team that I mentioned before, that are the stakeholders from the Catalyst to the Dental Advisory Committee. There seems to be a focus now on oral health and overall health that we've known all the time, but it seems to be getting more traction now. And I think that's something that's so very important when it comes to the new moms, pregnant moms, because we know of the gingival situations that can come about. For adult dental, we brought on up to 3 cleanings per year by medical necessity, and that's by dentist and dental hygienist decision. And some of that is because adults haven't been in for a while, but that also can work for new moms as well. And one of the things that the reason they up to 3 cleanings a year can work for adults is because we recognized diagnostic and preventive was very strong with the numbers for pregnant women. In doing it for adults, it will help reacclimate adults when many of them have been out of treatment, dental treatment for some time. So we still do pregnant services under the 60-day postpartum. However, that is extended if the pregnant lady becomes an adult, because our services transition right over from pregnant women to adult if the member still has benefit coverage. And certainly a couple of things, a wholesome periodontal program for pregnant women is good, and we learned that that is also good for adults. And one of the things that should be done is we should study the reimbursement schedule. Now, as I close now, to stand up the programs I've spoke about today, from our Smiles for Children program, pregnant women benefits, and certainly adult dental now, it is quite helpful to have someone that can find themselves in the company of leaders with authority to make these programs happen. And this is important, be a drum major for the grassroots staff that can convert their own paper ideas into going live. It's important to have someone that can transition from that room where folk can make this decision to being a drum major with the grassroots folk that can make it happen. The one consistency in each of these programs I've spoken of since 2005 and before, the mainstay at the helm of each of these programs is the very moderator of this presentation we are a part of right now, and that's Attorney Cheryl Roberts. So it indeed takes a village. She, in the many ways, has been the mayor of that village. And with that, I will yield.
It's funny because I was just writing about you. Dr. Hairston was one of the 4 dentists of color that we brought in 2005. And at that time, we have to admit where Virginia was. We had dentists who walked out. And I think what's wonderful is that he stayed, and the other 4, they all stayed, and now he runs it. And not only runs it, was able to bring up dental care for 800,000 members. So wonderful. Thank you, Dr. Hairston. Thrilled. Okay, ready for questions? Okay, while you're waiting for these questions, what are you going to do? You're going to do your evaluation because you're going to say we did a wonderful job. And the reason we want you to say we did a wonderful job is because, believe it or not, we actually go backwards and we actually look at those things. So I'm seeing questions and I'm going to ask them as they're coming up. All right, Lynette, there's a question for you. How did you decide on 6 months instead of a year? And then what was the response to the increased cost of extending coverage? I too saw 57 million and said, ooh. Okay, this was before the days of ARPA. I mean, now we say, oh, 57 million, right. What message ultimately helped pass it in the first line?
Yeah, so thanks for the question. And so at the end of the day, the cost is what drove the decision on whether to move forward with either 6 months or 12 months. And so when we did the analysis, there were some budgetary constraints that prevented us from going a full-blown 12 months. And even though the American Rescue Plan Act now allows states to go up to 12 months under the state plan option, that same question is going to come up again, which is going to be funding. And I think every single state Medicaid program is going to have to address that particular issue. In terms of what ultimately pushed this forward, it was the results of the study committee. They reviewed 3 years worth of data. And as I indicated, 60% of the deaths were preventable. And so just with all of the advocacy around it, that is what ultimately made Governor Kemp decide to sign this into law.
Well, I can tell you, my colleague is on the line here listening, Sarah, and we have that. One of the things we're hoping Governor Northam will okay too for us. So we'll be back to you. I know that she's listening now. So her name is Sarah. When she contacts you, this is why, because we plan to be next. All right, let's talk about doulas a little bit. Jennifer, you got a bunch of questions. What percentage of pregnancies do you anticipate the doulas will utilize in the first year once they're fully implemented?
It's a really good question. We are focusing on building this workforce right now. So my very candid answer is, I don't think it will be a significant percentage of pregnancies. What we're focusing on in year 1 is significantly building the workforce so that we're able to offer community doulas to more of our members. And so I hope to return to you all at some point in the very near future with actual numbers on members served. But for this year, we're really focused on building.
What we're seeing is that our health plans are invested in the building of the workforce, and one gave a grant to try to train 400. So we're looking at that too.
that's exciting stuff, right? That's where you could really get to, we're going to try to serve 20% of members or 50% of members. Yeah, absolutely. It's cool.
And we share the same health plan, so I'll tell you who they are. Okay. Okay.
Offline.
Offline. Did you estimate the additional cost to Medicaid for adding the doula benefit?
Yeah, we have done some analysis. For the moment, we anticipate that the improvement in birth outcomes will really offset the cost of the doula service. So, we do recognize that a negative birth outcome leads to medical expenditures. And if we can avoid a few of those, we can afford all of the doulas, right? So, so at this moment, we're not considering it a significant budget impact.
Here's another question. I have the same question. The question was, doulas have not been necessarily receptive to vaccination. We have the same issue now in Virginia, which is the hospitals are saying you can't come into the hospitals being fully vaccinated. The doulas said that they felt that that was a barrier. Okay, how are you handling it in New Jersey?
It's a really good question. The governor has been rolling out different vaccine mandates. And so the doulas are considered to be the guest of the person who's in the hospital giving birth. And no mandate has been applied there yet.
This is a good question for Lynette and for Jennifer. Do you have community health workers, and are you working with them as well on the maternal issues?
Do you want to take that, Lynette, or?
Yeah. So in Georgia, we are working on it. We've got some more work to do in that area, but yes.
Yeah, we're partnering with Rutgers Echo to build community health worker training programs. Again, this is through our partnership with Department of Health. They're really in the lead on that. So they built the community doula training for us. If you imagine someone who is prepared as a doula, trained as a doula under a different program, they're ready to deliver a baby, but they don't yet have our community distinction. So Rutgers Echo set up a community doula training program for us so they could just build that onto the doula training they already had. So that piece is in their community health worker infrastructure. We're building lactation support as well. And then lots of other community health workers will also fit into that same construct. It's pretty cool.
It's funny. This is the reason I'm smiling at these questions, because I'm dealing with them on my side too, again with the doulas. How did you design your reimbursement structure? And did you use a minimum requirement for certification and training? And how did you encourage cooperation between the health systems and the doulas? I'm laughing because we copied what you were doing, but you could explain how.
Well, we set up an hourly rate for the home visits. We made that as generous as we possibly could within the limits of the Medicaid program. We also set up a specific rate for labor and delivery. The challenge for labor and delivery is that a labor could be 2 hours or a labor could be 10 hours. So that certainly was tricky from a design point of view. But the way it's set up, you have the home visits at a specific rate, you have the labor and delivery at a flat rate. So the home visits are hourly, the labor and delivery at a flat rate, and then the bonus payment, which is available if the member goes to their postpartum OB visit.
I'm going to ask this, even though it's not here. One of the things we got challenged with is that once we start to establish the rate, the OBGYNs came back and said that they wanted a raise. Did you have the same issue, or?
We are always hearing from our providers about needing raises, but we have certainly heard from midwives and OBs recently. Yeah. Oh, and you mentioned managed care a minute ago, Cheryl. I just wanted to point out our managed care partners have been phenomenal about this, similar to your experience. That is a little bit overwhelming for doulas, right? When 5 health plans are calling me like, come contract, join our network, right? And we're saying to them, do it, do it, do it. And the doula is like, what's going on? So that is an intense experience, right? For a doula to be kind of working through that. So just a word of caution there.
That's because you had told us that. What we did was, and for other states, we had the managed care be actually in the implementation meeting, so they became
Mhm.
almost part of the group and part of
Yeah.
the discussion and help.
Yeah, really did.
Dr. Hairston, jumping to you first. You mentioned giving oral health package to the OBGYN. Any other reflections on opportunities of the medical and dental provider system coordination and collaboration that you want to discuss?
Yes, there was discussion at one time about potentially doing webinars of sorts for the medical doctors in an effort to bring them on board. There was discussion about posters in offices in an effort to try to have new moms more aware. Some of them never took off as much as I think I would like. One of the things I actually spoke with a dental office about, because they were advertising on radio, is doing segments on gospel radio. And there was much pickup from that.
I do remember that. I do remember. The other one that was asked for you is, how did you address non-coverage barriers like transportation and childcare? Or is it too early to have a discussion?
Transportation is provided for appointments. Is what I can say for that, for adult dental and for pregnant women benefits. And for the younger Smiles for Children, if necessary as well.
I would love to see, of course, dentists to have more weekend hours and evening hours, but of course we will get there. All right, and there is one other big question, and I'm only bringing it, it's a little long. Jennifer, you may have to do it afterwards, but we'll start it. It said, it's understanding that doulas have been certified in some way to qualify for Medicaid funding. Did you set up a new pathway for the certification or license for doulas to access Medicaid funds? And the reason this is obviously coming from Washington. So they're asking, Washington is calling us too. We're working with community doulas to make that process not overly burdensome. Minnesota, we all talked to them, had the same about New Jersey doulas, about the benefit, and are looking at changing our statute and SPAs and are referencing this guidance to allow for non-licensed providers to provide preventive services. So if you can talk about the certification process and how did you able to do that?
Yeah, and I would love to talk. I would love to have my brilliant team talk offline with other states. Cheryl, you know that we've been actively chatting with other states on this because it was a really significant effort to get through, working with doulas on getting their NPI, right? And when you get your NPI, you become part of a national registry. That has nothing to do with us. Your national registry information is the address you provided to them. For many doulas, that's their home address. And now they're going, oh my gosh, my home address is on a national registry, right? So there's a lot of technical details to work through. My team has really done a wonderful job with that. That kept us busy during the pandemic, right? If we didn't have enough to do. And so we have landed on some community doula programs. They are trained that way, and we accept their training without any further requirements other than, you know, the Medicaid essential stuff. And then we've said, if you are trained by these other doula programs and you do the Rutgers Echo community doula training to add on to your doula training, then we can bring you in as well. And we agreed that we would revisit over time, you know, maybe we can broaden out the programs that we consider acceptable community doula training. But for right now, we've laid out the specific ones that are that. And then if you have other doula training that you can document for us that we can verify, then we can just add on that Rutgers community doula training, and that gets the job. Think of it as an extra module to make sure that they're prepared for that side of things. And there's tons more information on our doula website. We're very happy to collaborate. Don't reinvent the wheel. We can all work together on that, right?
And guess what? That was an hour. We did it that fast. First of all, I gotta thank you all. Thank you all for doing this. I know it was a big favor. Thank you very much. I hope people who are listening heard heard good things and things that they want to follow up on. Don't forget the evaluations. You wanted the presentations. The presentations are online. You can get them right now. The whole series and actually get to hear it will be on demand. But most of all, I just hope that you will continue with the conference and continue to learn. And if you got anything out of this, that you help improve maternal and child health care. Thank you all for doing this.
Thank you.